Hello everybody, it's Dr. Ryan here. I'm a board certified specialist internist. Thank you so much for joining me in our 15th OSCE episode. Yep, we are tackling the infamous diabetic retinopathy. If you haven't yet subscribed to my channel, I strongly encourage you to smash that subscribe button, like and share this video. Thank you so much. Alright, this is the stem of our question. Today, we have a 67-year-old female with type 2 diabetes mellitus for the last 20 years, or DIA, presenting to you with a complaint of diminished visual acuity. Fundoscopy image is shown alongside. So the question goes as follows: describe the image for 2 marks. Then, what is the diagnosis for 1 mark? Outline a management plan for 4 marks. So as you can see, this is a beautiful funnel photo. And what we can see here is multiple hard exudates. Let me just get my pointer in there. You can see numerous hard exudates. See these very yellow areas here. Speaks to hard exudates. And we also got these tiny dot and blot hemorrhages. There's no neovascularization. So neovascularization is a long word which basically means new vessels, right? So what happens is, because of the ischemia to the retina, there's production of pro-angiogenic factors, chiefly vascular endothelial growth factor. And the claim to fame of VEGF is that it causes formation of new blood vessels. But these new blood vessels are very weak and friable, and they tend to rupture. And when they rupture, they bleed. Hence, you got the dot and blot hemorrhages. When these hemorrhages heal, they may actually cause vitreal hemorrhage. And when those heal, they heal with detachment of the retina. So it's a progressive scenario. Okay, so like we said, hard exudates are lipid exudates, and they manifest as yellow or white deposits. Dot and blot hemorrhages represent leakage of capillaries to the retina, and they appear small and red. Cottonwool spots appear gray with soft edges. These are basically representative of ischemia or an infarct to the retinal nerves. So what's the diagnosis? I'm sure you already got this one here. It's non-proliferative diabetic retinopathy. If we were seeing evidence of new vessels and neovascularization, then we can call it proliferative, but we don't. So this is non-proliferative diabetic retinopathy. Outline management plan. So obviously, for this lady, we would advise tighter glycemic control, right? Because she's elderly, we'll aim for an A1C between 7 and 8%. But if she was younger, an A1C between 6 and 6.5% is a better idea. To this end, dietary and exercise measures, you can refer her to a dietitian for the dietary plan. Control other cardiovascular risk factors, very important. So do a lipid screen, treat her for dyslipidemia, check her blood pressure, all right, get those cholesterols down, and of course diet and stop smoking. And of course, prompt ophthalmology referral. Okay, this is a nice summary slide showing us what a normal retina looks like and what it looks like in the situation of diabetic retinopathy. So we can see here the fovea and the macula. This is the center of greatest visual acuity. Then we have the optic disc, from where we have the optic nerve, exiting. And here we have the central retinal vein, retinal artery, retinal venules, and arterioles. So in diabetic retinopathy, we have, pre-proliferative, proliferative, and then maculopathy, right? So you got hard exudates here, cottonwool spots, which are the gray areas of infarction. Here's an aneurysm along the retinal vessel. Here's what we were talking about, abnormal growth of blood vessels, what we call neovascularization. And these are hemorrhages. Okay, so a very important landmark trial in the history of diabetes was the UKPDS, called the United Kingdom Prospective Diabetes Study. It was done in September 1998. From there, we had a lot of findings which dictate our current management of diabetes. So it was found in the study that in patients with type 2 diabetes mellitus, pharmacological blood glucose control with sulfonylureas or insulin significantly reduced the risk of microvascular complications, but not macrovascular complications. It was also found that metformin therapy significantly reduced diabetes-related and all-cause mortality. Strict control of blood pressure in type 2 diabetes also reduced the risk of both micro and macrovascular sequelae, along with diabetes-related mortality. Okay, my friends, I just want to talk a little bit about God's grace. In times past, we said that God's grace is God's divine enablement, which helps us to accomplish His divine mandate for us, right? And just like an electrical switch, so an electrical switch is essentially two wires which come into contact with each other, right? So God's grace is available to us. But unless we close that switch by faith, we will never access the grace that allows us to have power to do His will. My prayer for you and I is that we will close that switch by faith, allowing His grace to enter into our lives and making us powerful, effective, and victorious. I'll see you soon with another helpful video on my channel. God bless you.